Hi students, I am Dr. Sakshi Arora Hans, your Obs and Gynae faculty. And today I am here for all the FMGE students who are going to appear for their exam on 31st of August. I'm sure students that you must have completed all your subjects by now, and this is the time when you are looking for rapidly revising the subject. And for that purpose only, I'm here to help you in revising Obs and Gynae rapidly. Now, just in case you have not been able to complete any subject, please don't leave that subject. What you need to do is do the previous year papers, at least 4 to 5 papers. Whatever questions were asked in that paper, note those questions down and read those topics at least, right? Don't leave any subject completely. See, because that is going to always give you tension. That will be an area, because you wouldn't have studied that subject, your confidence level will be low. If you do this much also, your mind will say that you have completed all the subjects and your confidence level will be very, very high, right? Now, as far as Obs and Gynae is concerned, what I have done is topic-wise, I have made notes for you for all the important points which I want you to know in that particular topic. I am not going to explain those topics to you. What I want you to do is, as I am speaking, I want you also to copy those points. These are the golden points which you need to know in Obs and in Gynae. Note all these points and then revise these points at least twice or thrice before you go for your exam. If you are getting straight liner questions, like in AIMS this time we had many straightforward questions, then around 80 to 90% of questions will be covered in these sessions. That is what I believe. Except for the ones which are clinical questions. Clinical questions need concepts, right? And in the small span of time, I cannot help you in building your concepts. But for straightforward question, this session, what I'm going to take is very useful. I'm going to take separate session of Obs and separate session of Gynae. Right? And later on, after a week, I'm also going to take a separate session on images and important instruments for your exam related to Obs and Gynae, right? So let's get going. Let's talk about the important points in Gynae. And the first topic which we are going to start with is the menstrual cycle. The first thing what you have to know is that menstrual cycle or the ovarian cycle, it is initiated by the hormone FSH. So at the time of puberty, the hypothalamic pituitary ovarian axis becomes active, and from the pituitary FSH is released, and this FSH initiates the ovarian cycle. So that's a single line which you have to copy, that ovarian cycle is initiated by FSH. Now this FSH acts on the granulosa cells in the ovary, and from the ovary it will release estrogen and inhibin B. So from the granulosa cells, two hormones are released. One is estrogen and the other is inhibin B. Now from here only what you should understand is, suppose you haven't studied ovarian cancer and a question comes that what is the tumor marker for granulosa cell tumor? I am telling you that granulosa cells secretes two hormones, estrogen and inhibin B. So the tumor marker for granulosa cells tumor of the ovary will also be any one of these, and it is inhibin B. So number one point, that is what you should know about the granulosa cell tumor of the ovary. Now from this discussion also this becomes clear that this means that the granulosa cell tumor of the ovary will also release estrogen. In other words, granulosa cell tumor of the ovary is a feminizing hormone, right? Now the main hormone which is there during first half of the menstrual cycle, and the first half of menstrual cycle is called as the follicular phase or the proliferative phase or the pre-ovulatory phase, is estrogen. Third important point. Next important point is estrogen. It has a positive feedback on LH and it has a negative feedback on FSH. Because estrogen has a positive feedback on LH, so the levels of LH suddenly increase, and that is called as LH surge. So if they ask you LH surge is due to, you are going to say LH surge is due to estrogen. Next question which they ask you is, when is the peak of estrogen seen? The peak of estrogen is seen on day 12 of the cycle, whereas the peak of LH is seen on day 13 of the cycle. And later on, again, I'm going to tell you that the peak of progesterone is seen on day 22 of the cycle, right? Then, this over here, I have made the LH surge. So LH surge is starting from here. So the levels of LH have started increasing. The next question which they ask you is, what is the time interval between LH surge and ovulation? All of us know that ovulation is due to LH surge, right? So what is the time interval between LH surge and ovulation? The best answer is 32 to 36 hours. And if that is not given, then the second best answer is 24 to 36 hours. Be very careful if they are asking you LH surge, time interval between LH surge and ovulation, or whether they are asking you between LH peak and ovulation. The time interval between LH peak and ovulation is 10 to 12 hours, right? Now, when I say ovulation, what happens in ovulation is that meiosis 1 is resumed, right? Now, if you remember your oogenesis, you will remember that oogenesis began in the intrauterine life, and in the intrauterine life, the oogonia, they got converted into primary oocyte. Primary oocyte then started undergoing meiosis 1, but this meiosis 1 was arrested. And they ask you, in which phase was meiosis 1 arrested? So meiosis 1 was arrested in prophase, right? And this meiosis 1 is resumed at the time of puberty. And why it is resumed at the time of puberty? It is resumed due to the hormone LH, right? So because of LH surge, meiosis 1 is resumed, right? And this primary oocyte will then get converted into secondary oocyte. You can see here the primary oocyte is getting converted into secondary oocyte, and the first polar body is released. Now, another very important point which you have to note over here is that in meiosis 1, there is reduction in the number of chromosomes. So here in primary oocyte, the chromosome number was 46XX, and now the chromosome number will become half. So secondary oocyte will have 23X and first polar body will have 23X, right? Now this primary oocyte, which was formed in intrauterine life, it will remain like this till puberty, right? Because this happened in intrauterine life. So this primary oocyte in the ovary, it gets surrounded by follicular cells. The primary oocyte gets surrounded by follicular cells, and this structure is called as the follicle, right? So these are the follicular cells, as you can see in the image, and the primary oocyte. So this is called as the follicle, right? So next question which they ask you is, just before ovulation, what is the size of the follicle? So the size of the follicle just before ovulation is 18 to 20 millimeter. Very, very important, right? Next question which they ask you is that they give you the length of the cycle and they ask you to calculate the day of ovulation. So always remember, if they give you the length of the cycle, from that you have to subtract 14. And that is how you get the day of the ovulation. That's very, very important. So if the cycle length is 36, then the day of ovulation becomes 36 minus 14, that is day 22, right? Next question is, what is the first sign of ovulation on endometrial biopsy? The first sign of ovulation on endometrial biopsy is appearance of subnuclear vacuoles. Appearance of subnuclear vacuoles. That's the first sign of ovulation on endometrial biopsy. Next, very important set of questions is asked on the number of follicles. Maximum number of follicles are seen in the 5th month of intrauterine life, that is at 20 weeks, and at that time the number is 6 to 7 million. So once in FMGE they had asked that maximum number of follicles which can be seen in the ovary are, so maximum number which can be seen are 7 million, and that 7 million is seen at 5th month of intrauterine life, that is 20 weeks of intrauterine life. At birth, the number of follicle becomes 1 to 2 million, and at puberty, it is 4 to 5 lakh. Now, then comes after ovulation starts the second half of the cycle. So the second half of the cycle is called as the luteal phase or the secretory phase or the post-ovulatory phase. Now, in the post-ovulatory phase, the main hormone is progesterone. Now, what you have to understand here is, what is ovulation? See, this step over here, which I told you, that when a primary oocyte, it gets converted into secondary oocyte, this is called as ovulation, right? And we already did that meiosis 1 is resumed because of LH surge, and ovulation is also because of LH surge. This step is called as ovulation. Now, at the time of ovulation, the primary oocyte is getting converted into secondary oocyte. What is happening to the follicle? This follicle, it gets converted into corpus luteum. So after ovulation or at the time of ovulation, corpus luteum is formed, right? Now, next very important thing is, what is the effect of progesterone on LH? So progesterone, the moment progesterone is released, it will decrease the LH. Estrogen was decreasing FSH and it was increasing LH. Progesterone, when it is released in high concentrations, it decreases the LH. And from where did this progesterone come? This progesterone came from corpus luteum, right? So let's talk about corpus luteum. Now, corpus luteum, it is formed in non-pregnant females also, and just in case the female has conceived, then also the corpus luteum will be formed, and that will be called as the corpus luteum of pregnancy. So what are the hormones which are released by corpus luteum? The main hormone which is released by corpus luteum is progesterone. Apart from progesterone, corpus luteum also releases estrogen and it releases inhibin A. If you remember, just now I told you inhibin B was released by the granulosa cells, right? The corpus luteum of pregnancy will release all these three hormones, plus it is going to release relaxin, right? Now, corpus luteum in a non-pregnant female is maintained by the hormone LH, whereas corpus luteum in pregnancy is maintained by hormone HCG. That is why we say that LH and HCG are functionally the same hormones. The lifespan of corpus luteum in a non-pregnant female is 12 to 14 days, whereas in pregnancy, the lifespan of corpus luteum is 10 to 12 weeks, right? Now, the maximum size of corpus luteum, in other words, maximum progesterone in the cycle, in other words, when there will be maximum progesterone will have a negative feedback on LH. So the lowest level of LH in the entire cycle will be seen on day 22 of the cycle. So this question can be asked anyways. They can ask you maximum size of corpus luteum, or they can ask you when are the levels of progesterone maximum in the cycle, or they can ask you when are the levels of LH lowest in the cycle. You should remember it is day 22 of the cycle. Now, day 22 of the cycle means, quickly I'll explain you here, that this over here is day 14. In a 28-day cycle, ovulation occurs on day 14, and if I am saying day 22 of the cycle, this means how many days after ovulation? This means 8 days after ovulation, right? Now, all the tests for ovulation to know whether a female is ovulating or not, they are based on the presence or the absence of progesterone. If a female is ovulating, then the progesterones will be present. If the female is not ovulating, then progesterone will be absent. So if I want to know whether a female is ovulating or not, on day 22 of the cycle, I will check her progesterone levels. Right, all the tests for ovulation, they are done on day 22 of the cycle. Right, so this is what you needed to know about the menstrual cycle. Apart from this, you should know the characteristics of menstrual cycle. Very, very important. The length of the menstrual cycle, it is between 21 to 35 days, average length being 28 days. Number of days of bleeding is 2 to 7 days, and average days of bleeding being 4 to 6 days. Normal blood loss in a menstrual cycle is 5 to 80 ml. Average blood loss, the best answer would be 30 ml. If 30 ml is not given in the options, the second best answer will be 35 ml. And if that is also not given, then the third best answer will be 50 ml, right? Then certain important terminologies which you need to remember are, number one is menorrhagia. What do you mean by menorrhagia? Menorrhagia means excessive bleeding which is happening at regular intervals. And how much excessive? More than equal to 85 ml of blood loss, or if bleeding is happening for more than 7 days. Right? So the term for excessive bleeding is menorrhagia, and menorrhagia is seen in fibroid. Right? Then the second term is hypomenorrhea. Hypomenorrhea means less bleeding which is happening at regular intervals. How much less? Less than 5 ml or less than 2 days. Right? And hypomenorrhea is seen in case of Asherman syndrome. Third problem can be oligomenorrhea. Oligomenorrhea means that the cycles are very long. In other words, the number of cycles in a year are less, right? So long cycles, in other words, or they can say the number of cycles in a year are less, then the term will be oligomenorrhea. And in contrast, polymenorrhea means short cycles. In other words, the number of cycles in a year will be more. What is metrorrhagia? Metrorrhagia means if a female is having bleeding at irregular intervals, or if she is coming to you with complaint of intermenstrual bleeding, then that is called as metrorrhagia. Metrorrhagia is seen in polyp. Metrorrhagia is not seen in fibroids. In fibroids, you get menorrhagia. There will be excessive bleeding, but it will be happening at regular intervals, right? Then you should know about pain at the time of menstruation. Pain at the time of menstruation, that is called as dysmenorrhea. This dysmenorrhea, it can be primary or it can be secondary. Primary means it's idiopathic, right? We don't know that why this dysmenorrhea is happening. And mostly it is because of the release of PGF2 alpha. So if someone asks you that which prostaglandin is released at the time of menstruation, it is PGF2 alpha, and it is this PGF2 alpha which leads to pain at the time of menstruation. Secondary dysmenorrhea means that it is happening because of some pelvic pathology. So there is a pelvic pathology which is causing that dysmenorrhea, and the most common pelvic pathology which leads to secondary dysmenorrhea is endometriosis, a very hot favorite question for FMG students, right? Followed by PID. Then secondary dysmenorrhea can also be caused by fibroid or by copper T. Right? So primary means it's idiopathic, secondary means there has to be a cause, like most common is endometriosis. Now about primary dysmenorrhea, you have to know that primary dysmenorrhea, the pain begins on day 1 of the cycle. So whenever a female bleeds, that is called as day 1 of the cycle, right? So bleeding doesn't happen at the end of the cycle, bleeding marks the beginning of the cycle, right? Now, so if in case of primary dysmenorrhea, pain will start on day 1 of the cycle, and as the bleeding will progress, when the menstruation will begin and as the number of days will pass, the intensity of the pain will decrease. Third thing, very important thing which you have to remember about primary dysmenorrhea is it is related to the age of menarche. That means the younger the age at which a female starts menstruating, there are more chances of having dysmenorrhea. So 3 important points on primary dysmenorrhea. It starts on day 1 of the cycle, and as the bleeding progresses, the intensity of the pain decreases, and it is related to the age of menarche. The treatment for primary dysmenorrhea is you have to release the spasm, so you should give antispasmodics like mefenamic acid, right? Then in secondary dysmenorrhea, what you have to remember is that secondary dysmenorrhea is spasmodic and congestive dysmenorrhea. So there is congestion also, and congestion will not happen unless and until there is a pelvic pathology, right? In this case, pain will be present before the period also, and it will persist even if the period comes, right? So with bleeding also, the pain is going to persist for some time. So pain will not be relieved with the onset of menstruation. Whereas in case of primary dysmenorrhea, the pain would be relieved at the onset of menstruation, right? Management for secondary dysmenorrhea is that you have to treat the underlying cause. If the underlying cause is endometriosis, you have to treat endometriosis. If the underlying cause is fibroid, you have to treat the fibroid. So that is pain at the time of menstruation. Sometimes in your questions, you are going to get that a female is complaining of mid-cycle pain. Now, whenever you get a complaint like this, she is getting mid-cycle pain, cyclical pain in the abdomen in the mid of the cycle. That means pain is happening at the time of ovulation, and that is called as Michel-Merz syndrome. That is how the question will also come to you. The female is coming to you with mid-cyclical pain. So always it means it is pain at the time of ovulation, which is called as the Michel-Merz syndrome, right? So these were the important points which you needed to know on the topic of menstrual cycle. Now the important points which you need to know on hormones. So let's talk about hormones. Now when we talk about hormones, the first hormone which you should be knowing is estrogen. Natural estrogen is E1, E2, E3 and E4. E1 is estrone, ONE1, that is estrone. It is most common estrogen in a postmenopausal female. E2 is estradiol, and it is the most common estrogen which is seen in reproductive age group, and also it is the most common estrogen seen in pregnancy, right? Then E3. E3 is estriol, right? It is the most specific estrogen in pregnancy. And then you have E4, that is estetrol, tetra. So the name itself is going to tell you whether it is E1, E2, E3 or E4, and the important questions on E1, E2, E3 and E4 I have told you. Remember that the most common in pregnancy is E2, but the most specific in pregnancy is E3, right? The next question which they ask you is to arrange the estrogen, the natural estrogen, in the order of potency. Suppose they have asked you in decreasing order of potency. So then remember, the most potent is E2, followed by E1, then E3 and then E4. So the most potent estrogen is E2. Other important points which you have to remember on estrogen is that estrogen helps in bone formation, it is cardioprotective, and it increases the clotting factors. That is why OCPs are contraindicated in patients of venous thrombosis, right? Because estrogens, they increase the clotting factors. That is what you have to remember on estrogen. Coming to progesterone. Now, progesterone, what you have to remember is that the source of progesterone, just now we saw that in a non-pregnant female, the source of progesterone was corpus luteum. In pregnancy, in the first 10 to 12 weeks, the source of progesterone is corpus luteum of pregnancy, and after that, the major source is placenta. So after 10 to 12 weeks until entire pregnancy, the major source of progesterone is placenta. Now there are certain properties of estrogen and progesterone which you have to remember, that how estrogen and progesterone act on the various organs. So how estrogen acts on the uterus, what estrogen is going to do is, estrogen is going to proliferate the uterine endometrium, and because estrogen proliferates the uterine endometrium, that is the reason why estrogen should never be given alone to a female of reproductive age, because it will lead to endometrial cancer, because estrogen proliferates the uterine endometrium. On the other hand, what progesterone does is, progesterone supports the endometrium. That is called as the secretory action. So it supports, I'll write it a little better, it supports the endometrium, right, which is called as the secretory action, right? Then effect of estrogen on cervix. Under the effect of estrogen, cervical mucus will be thin, it will be watery, it will be copious, a lot of cervical mucus will be there, and it will be elastic. That means it can be stretched between fingers, and that is called as spin Barkeet. So they will ask you, spin Barkeet is because of the presence of, so spin Barkeet, that is elasticity of the cervical mucus, is because of estrogen. And under the presence of estrogen, when the cervical mucus will be seen under microscope, you will get fern-like appearance. This is called as ferning, a very, very important question. So they ask you, ferning is due to, again, ferning is due to increased estrogen as well as increased sodium and increased chloride, right? So ferning is because of increase in estrogen, increase in sodium and increase in chloride, and it is because of estrogen. Mainly it is because of estrogen. Now, under the effect of progesterone, cervical mucus will be exactly opposite. It will be thick, it will be scanty, and it will be non-elastic. No ferning will be seen under microscope. Now, the question which they ask you is, on which day of the cycle ferning is lost? So remember, ferning is lost on day 18 of the cycle. All these points are very, very important points. I want you to note each of these points, right? Then, under the effect of estrogen in vagina, you are going to get superficial cells. Now, how are the superficial cells? How do they appear? Superficial cells, they are pink colored cells. So, you are going to see that if you are going to take a sample from vagina, in the first half of the menstrual cycle, you will see that it will have pink colored cells, and these pink colored cells with the pycnotic nucleus, it is called as superficial cells. Whereas if you see the vaginal epithelium, if you study the vaginal epithelium in the second half of the menstrual cycle, you will get blue colored cells which are called as the intermediate cells. So these are basophilic cells called as the intermediate cells. They will have a little larger nucleus than the superficial cells. So under the effect of estrogen, you will get eosinophilic cells, which are superficial cells, and under the effect of progesterone, you will get basophilic cells, which are the intermediate cells, right? So this means vaginal epithelium study can tell you which hormone is predominating in a female at that time. So the question which they ask you is, from where should you collect a sample from the vagina for hormonal study? So for hormonal study, sample should be collected from lateral wall of vagina. Sample should be taken from the lateral wall of vagina. Right? Very, very important question. Right? Now, apart from these actions, what progesterone does is, progesterone is a thermogenic hormone. It increases the basal body temperature of a female by 0.2 to 0.5 degrees Celsius. So these are all the important points which you needed to know on estrogen and on progesterone. Let's quickly move to the other hormones, that is LH and FSH. Now, about LH and FSH, what you need to remember is that normally LH and FSH in a female are equal. So the ratio of LH is to FSH in a normal female is 1:1, or sometimes it can even go as 1:2. So FSH either will be equal to LH, or normally FSH can be a little higher than LH. In PCOS, this ratio becomes reversed. In PCOS, the ratio of LH is to FSH becomes 2:1 or 3:1. Now, I want you to be very, very careful when you are answering questions like this. If they are asking you ratio of LH is to FSH in PCOS, the answer is 2:1 or 3:1. But if they are asking you FSH is to LH, so whichever is written first, you have to keep that in mind. If they would ask you FSH is to LH, then it will become 1:2 or 1:3, right? Now, the next question which they ask you is, what is the best time for LH and FSH testing? The best time for testing LH and FSH is day 2 or day 3 of the cycle. Synthetic LH and FSH is called as HMG, that is human menopausal gonadotropin. Human menopausal gonadotropin, right? Now, this table which I have made here is one of the very, very important tables. In which condition are you going to get decreased LH and FSH? In which condition you are going to get increased LH and increased FSH? And in which condition LH is increased but FSH is decreased? So let's start this table quickly. The conditions in which LH and FSH both are decreased, you can remember by a mnemonic PKOS. Instead of PCOS, it is PKOS, where P stands for pregnancy. In pregnancy, LH and FSH both are less. Why? Because in pregnancy, you have excessive progesterone, and we know that progesterone decreases LH. In pregnancy, we have excessive estrogen, and we know that estrogen decreases FSH, right? Second P stands for prolactin. Whenever the levels of prolactin are high, prolactin decreases GnRH, and because prolactin will decrease GnRH, so LH and FSH will automatically decrease. And third condition is pituitary failure. You all know that LH and FSH are released from the pituitary. So if pituitary failure will happen, obviously the levels of LH and FSH will be less. K stands for Kallmann syndrome. Now, in Kallmann syndrome, there is hypothalamic failure. So, the hypothalamus of the person is not functioning and the levels of GnRH are less. Obviously, if the levels of GnRH are less, then the less GnRH will be acting on pituitary, and so the levels of LH and FSH will also be less. Again, in OCPs, there is less LH and FSH. Why in OCPs there is less LH and FSH? Because in OCPs have estrogen and progesterone. And again, the same thing. Because OCPs have estrogen and progesterone, so this estrogen which you will take is going to have a negative feedback on FSH, so the levels of FSH will decrease, and this progesterone will act on LH, and so the levels of LH will decrease. Sheehan syndrome. In Sheehan syndrome, there is anterior pituitary gland necrosis. There is necrosis of the anterior pituitary gland because of postpartum hemorrhage. So it is postpartum necrosis of the anterior pituitary gland, and obviously if anterior pituitary gland has necrosed, LH and FSH are released from the anterior pituitary, so the levels of LH and FSH have to decrease, right? Now, in which conditions is LH and FSH increased? Now, LH and FSH is increased in menopause because in menopause both estrogen and progesterone are less. So, if estrogen and progesterone will be less, the negative feedback on LH and FSH will be gone, and so both LH and FSH will increase. And levels of LH and FSH are high in Turner syndrome because in Turner syndrome the ovaries are streak. They have streak gonads, and obviously if they have streak gonads, they don't have proper ovaries. So again the levels of estrogen and progesterone will be less, and if estrogen and progesterone will be less, the negative feedback on LH and FSH will be gone, so the levels of LH and FSH will increase. So please remember that there are two conditions in which LH and FSH are high: menopause and Turner's syndrome. Very, very important two conditions. And the conditions in which LH and FSH are decreased are P, K, O and S. Now, if your question says that the levels of LH are high but FSH is low, then it is PCOS, that is also called as the Steen-Leventhal syndrome. What is PCOS? Polycystic ovarian syndrome. So just now we saw that in PCOS, the ratio of FSH is to LH becomes 2:1 or 3:1. In other words, the levels of LH are high but the levels of FSH are low, right? So this is what you had to know about hormones in gynae. I hope all of you are writing these points simultaneously, and these are the points which I want all of you to revise before you go for your exams, and I will also tell you how you are going to revise these points right at the end of the session. So let's continue with the session. The third important topic which I have to tell you important points is on embryology. So on embryology, the first thing what you need to know is from where do the female reproductive organs they develop from. See, ovaries or gonads. Now whether it is ovary in females or whether it is testes in males, it develops from the genital ridge. The uterus, fallopian tube, cervix and upper two-thirds of vagina, they develop from the Mullerian duct, or which is also called as the paramesonephric duct. All of you know that in an embryo, initially there are both the ducts, the Mullerian duct and the Wolffian duct. In females, the Mullerian duct grows, whereas in males, it's the Wolffian duct which grows. right? Another name for Mullerian duct is the paramesonephric duct, and another name for Wolffian duct is the mesonephric duct. Remember, M and M are not together. So Mullerian will not be called as mesonephric. Mullerian will be called as the paramesonephric duct. The upper 2/3 of vagina is developing from Mullerian duct, but the lower 1/3 of vagina develops from the urogenital sinus, right? Point to note over here is that the ovaries are not developing from Mullerian duct. Ovaries are developing from genital ridge. So in those cases where both the Mullerian ducts are absent, which is called as Mullerian agenesis, ovaries will be normal. In other words, a patient of Mullerian agenesis will be ovulating normally. Very, very important question, asked at least twice or thrice. Because ovaries have nothing to do with Mullerian duct, ovaries develop separately from genital ridge. So even if Mullerian ducts are absent, ovaries will still be present, right? The next very important question is, from where does vaginal epithelium develop? Vaginal epithelium develops from the endoderm of the urogenital sinus. Now, I told you just now that in males, it's the Wolffian duct which is going to grow and the Mullerian duct will regress. Why does Mullerian duct regress in males? That is because Mullerian inhibiting substance or anti-Mullerian hormone is released by the Sertoli cells of the testes. Because the Sertoli cells of the testes will release anti-Mullerian hormone or Mullerian inhibiting substance, so the Mullerian duct will regress in males. And what are the remnants of Mullerian duct which can be seen in males? There are two remnants, very, very important. You cannot afford to forget them. These are the prostatic utricle and the appendix of testes, right? Similarly, I told you in females, the Wolffian duct regresses. Why the Wolffian duct regresses? That is because Wolffian duct grows due to testosterone. So for the growth of Wolffian duct, testosterone is needed. And in males, from Leydig cells, testosterone is released. And because testosterone is released from the Leydig cells in males, the Wolffian duct will grow. But in females, because there is no testosterone in intrauterine life, that is why in females, the Wolffian duct will regress, right? So Mullerian duct regresses in males because of the secretion of anti-Mullerian hormone from Sertoli cells. Wolffian duct regresses in females because of the absence of testosterone. Right? Now, when Wolffian duct will regress in females, the remnants which are going to be seen in females are going to be number 1, Gartner's duct, number 2, Epo-oophoron, number 3, Para-oophoron, and number 4, Cobalt tubercle. Right? Now, there is something which is very important, and that is the gene responsible for sex determination. The gene which is responsible for sex determination, that is the SRY gene, that is the sex-related gene which is present on the short arm of Y chromosome. Right? So which gene is responsible for sex determination? The gene responsible for sex determination is SRY gene. And this SRY gene, where is it present? It is present on the short arm of Y chromosome. Very, very important. This SRY gene, it will target on another gene, and the target gene for SRY gene is the SOX9 gene. But the most important gene which is responsible for sex determination is the SRY gene, which is present on the short arm of Y chromosome. So if Y chromosome is present, the sex of the baby becomes male, because if Y chromosome is present, the SRY gene will be present and the sex of the baby will become male. If Y chromosome is absent, then SRY gene will be absent and then the sex of the baby will become female. The best investigation for sex determination is karyotyping, right? Now, then you should also know what are homologous organs. Now, what are homologous organs? Homologous organs, they are those organs in male and female which have the same embryological origin. So organs in male and female which have the same embryological origin, they are called as the homologous organs, right? So make a table, on one side females, then males, and from where do they originate. So The homologous organ in female, if we talk about the homologous organs, the first organ is clitoris. The clitoris in female is homologous to penis in male, and both these organs, they originate from the genital tubercle. Very, very important. Another very important question which you have to remember is not only this but also this, that what is the lymphatic drainage of clitoris. The lymphatic drainage of clitoris is the lymph node of Clockway or the Rosenmuller lymph node. So clitoris drains into the lymph node of Clockway or the Rosenmuller lymph nodes. Then labia majora in females is homologous to scrotum in males, and both these structures, they originate from the genital swellings, right? Then labia minora in females is homologous to penile urethra in males, and both these structures, they originate from the genital fold. Remember that labia minora and majora will drain into superficial and deep inguinal lymph nodes, right? Then the prostate gland in males is homologous to Skene glands or the paraurethral gland in females. So over here, just what has happened is males has come on left side of the table and females on the right side. Remember that. Copy this properly. So prostate gland in males, and that's a question which has been asked twice. Prostate gland in males is homologous to Skene glands or paraurethral glands in females. Cowper's gland in males is homologous to Bartholin glands in females. Bartholin gland is also called as the greater vestibular gland. And gubernaculum in males is homologous to round ligament in females, right? So these are all the homologous list of the homologous organs which you should be knowing. Another very important point which you have to know is that the round ligament, where it is attached. So if this over here is the uterus, this is the angle of the uterus. Round ligament is attached to the cornua or the angle of the uterus, and from there it is going to come into the inguinal canal, and finally it will be attached to the labia majora. So on one side, inguinal ligament is attached to the cornua of the uterus, and on the other side it is attached to labia majora, right? And round ligament is homologous to gubernaculum in males. Clear? So this is what you had to know in embryology in this topic. When we talk about prolapse, the important points, first important point what you have to remember is what are the supports of the uterus. Now, supports of the uterus, number one, you have angle of anteflexion and angle of anteversion. This is how cervix, uterus and vagina are in the this is how they are placed. So if this over here is vagina, this is cervix and this is uterus, right? Then there is an angle between vagina and cervix which is called as the angle of anteversion. V for vagina, V for version. And then there is an angle between cervix and the uterus. This is called as angle of anteflexion. Now because uterus and cervix, they are anteverted and anteflexed, that is why they prevent prolapse, because over here is the bladder. The moment they try to come down, the bladder is going to prevent the prolapse, right? But if instead of anteverted, uterus is retroverted. This was anteverted, this is retroverted. Now, if uterus is retroverted, then it can easily come down, right? So the first step in prolapse is always retroversion of the uterus. So the first support, if you have to classify the supports, we have the first support as the angles, and these angles are angle of anteversion and angle of anteflexion, right? Then you have the ligaments which support the uterus. The ligaments which support the uterus are three ligaments. Number one, there is a ligament which comes posteriorly, and that is the uterosacral ligament. So it attaches uterus to the sacrum. Then we have a lateral ligament, that is the cardinal ligament, which is also called as the McEnroth's ligament or the transverse cervical ligament, which is, you can see from the figure, is attaching uterus to the lateral pelvic wall. And then you have a ligament which comes anteriorly, the pubocervical ligament. These three ligaments together are called as the triradiate ligament. So the uterosacral ligament, the cardinal ligament, and the pubocervical ligament. Right? So these are the ligaments which support the uterus. Amongst the ligaments, the strongest one is the cardinal ligament. Apart from these ligaments, secondary support is provided by round ligament. Now, I told you that round ligament, it was attached from the angle of the uterus. The round ligament came from the angle of the uterus and it came up till labia majora. Right? So, because of its attachment, round ligament helps to keep the uterus in anteverted position. And because round ligament helps to keep the uterus in anteverted position, it is a secondary support. It is not a primary support. And the ligament which does not support the uterus at all is the broad ligament. Right? So we had two angles which were supporting the uterus. We have three ligaments which are the main ligaments, and we have one secondary ligament. Apart from that, we have the muscles which support the uterus. The muscles which support the uterus are the levator ani muscle. Levator ani muscle, it hangs like a hammock, right? It hangs like a jhula. And it forms the pelvic diaphragm. That's a very, very important ligament. Just below the levator ani muscle, we have the deep transverse perineal muscle, and then we have the superficial transverse perineal muscle and the bulbospongiosus muscle. So these are the ligaments which are supporting the uterus. Apart from this, some support will also be provided by the urinary sphincter and by the anal sphincter. So these are all the muscles which support the uterus. Amongst the muscles, also the most important one is levator ani muscle, and overall also the main support of the uterus is the levator ani muscle, which forms the pelvic diaphragm, right? Now, if any of these supports, they become weak, and these supports can become weak because of repeated childbirth and because of menopause, then prolapse happens. Right, that is why prolapse is more common in elderly multiparous female. Now, one very important question which they ask you is that birth trauma is a risk factor for. So, birth trauma is a risk factor for prolapse. Now, how do you manage prolapse? Now, in prolapse, you can have uterine prolapse and you can have vaginal prolapse. So first, you have to understand how to manage uterine prolapse. Quickly, you have to make a table where on one side, you are going to write the condition and on one side, you are going to write how to manage it. Management of uterine prolapse, it always depends on the age of the patient and on the parity of the patient. That means whether the patient wants future childbirth or not, right? Suppose prolapse is happening in a young female or it is happening in a nulliparous female, or the question is saying it's a congenital prolapse, or question is saying that prolapse is happening in a female who wants pregnancy in future, then always and always the management is sling surgery. In the options, you will have to look for sling surgery. The name of the sling surgery can be any surgery. It could be a Purandare sling surgery. It could be a Shirodkar sling surgery. That doesn't matter. What you have to look for in the options is the word sling surgery. Instead of sling surgery, it can also be written as cervicopexy, right? So whenever question says that prolapse is happening in a young female or it's happening in a female who wants future childbirth or in congenital prolapse, the management is sling surgery. Second condition could be, they say that prolapse is happening in a reproductive age female who wants to retain her menstrual function, but she doesn't want any future children. She doesn't want reproductive function, but she wants to retain her menstrual function. In that case, the management is Fothergill repair or Manchester surgery. Third condition could be prolapse is happening in a female who's more than 40 years, who says, I do not want any menstrual function and I do not want any reproductive function also. In that case, the management is vaginal hysterectomy. The name of vaginal hysterectomy is Ward-Mayo's hysterectomy, right? Fourth condition can be, they say that prolapse is happening in a female who's more than equal to 65 years. She has diabetes, she has heart disease, in an elderly female. In that case, the management is Le-Fort colpoclysis. In Le-Fort colpoclysis, you do nothing but you just fuse the anterior and the posterior vaginal wall, right? And then if the vagina is closed, obviously uterus cannot come down, right? Now, if they say that there is a female who's pregnant and she has prolapse, or if they say that there is a young female who's not fit for surgery, right? Or if they say that there is prolapse in postpartum period after delivery. In all these conditions, I cannot do surgery. During pregnancy also, I cannot do a uterine surgery. Immediately after delivery also, I cannot do any surgery because I want the uterus to first come back to its normal size and normal position. Then only I can do a surgery. Or if the question is saying a young female is unfit for surgery, then how do you manage the prolapse? Then the answer is you are going to put a ring pessary, right? Now, this is how you manage uterine prolapse. And as I told you, management of uterine prolapse, it will depend on the age of the patient and it will depend whether she wants future children or not. But this is not the case for the management of vaginal prolapse. Vaginal prolapse, the management is same in all age groups and in all parities. Whether a female wants a child or not, the management of vaginal prolapse will not differ. Right? Now, in vaginal prolapse, you have to make a table where you are going to, on one side, write vaginal prolapse. Then you are going to write what is the terminology for that vaginal prolapse and how do you manage it. Now, in vaginal prolapse, it can be an anterior vaginal wall prolapse or a posterior vaginal wall prolapse. If the upper two-thirds of the anterior vaginal wall is prolapsing, it is called as cystocele, right? And if the lower one-third is prolapsing, it is called as urethrocoele. So quickly, I'll explain. Actually, without explaining, I also cannot remain. I have to explain a few things when I teach. So this over here is the enterocoele. Now look here. The anterior wall. This over here is the anterior wall, right? So if upper part of the anterior wall is prolapsing, it is related to the bladder and it is called as cystocele. And if lower part of the anterior wall is prolapsing, it is related to urethra, so it will be called as urethrocoele. In the posterior wall, if upper one-third is prolapsing, it is related to the pouch of Douglas, which has got the intestine, so it is called as enterocoele. Middle one-third is prolapsing, it is related to rectum, so it will be called as rectocoele. And if lower one-third is prolapsing, it is related to perineum and that will be called as laxed perineum, right? Okay, so now look here. If upper two-thirds of the anterior vaginal wall is prolapsing, it is called as cystocele and the management of cystocele is anterior colporrhaphy. If lower one-third of the anterior vaginal wall is prolapsing, it is called as urethrocoele and management of urethrocoele is also anterior colporrhaphy. So whether you have to manage cystocele or whether you have to manage urethrocoele, the management is anterior colporrhaphy, right? Now in posterior vaginal wall, if upper one-third of posterior vaginal wall was prolapsing, as I showed you in the image, it was called as enterocoele and the repair of enterocoele is Moskowitz repair, right? Now, if middle one-third was prolapsing, it was called as rectocoele and if lower one-third was prolapsing, it was called as laxed perineum. Now, repair of rectocoele and laxed perineum together is called as posterior colpoperineorrhaphy, right? So, repair of laxed perineum and rectocoele is called as posterior colpoperineorrhaphy. Now, this is all what you need to know in prolapse. So now let's see the important points which you have to remember about puberty. So the first very important thing is, what is the sequence of puberty in females? And for remembering the sequence of puberty in females, you should remember a mnemonic: gross BPH in males. Right, so that's a mnemonic where G stands for growth spurt. Now, growth spurt is the first sign of puberty in females, but that's not a very specific sign and that's not visible, right? So if they ask you what is the first visible sign or the most specific sign for puberty in females, that is B, breast budding or thelarchy. So the first sign is growth spurt, but growth spurt is not the best sign. It's not very prominent sign. So if they ask you the first visible or the most specific sign of puberty in females, that is breast budding or thelarchy, right? Then after breast budding or thelarchy, then next is P, which stands for appearance of pubic hair, that is pubarch, and appearance of axillary hair, which is adrenarch. Then you have H. H stands for peak height velocity. And then last to appear is the onset of menstruation, which is called as menarche. So this is the sequence in which puberty happens in female. Very, very important question. Now, breast development, that's a secondary sexual characteristic in a female. And for breast development, the hormone which is responsible is estrogen, right? So breast is a most important secondary sexual characteristic in females. So if you get a question where they say that secondary sexual characteristics are present, it primarily means that the breast is present. And if they say secondary sexual characteristic is absent, that means breast development is absent. Now, for pubic hair and axillary hair, the hormone which is responsible in females also is androgens. For breast development, it was estrogen, and for pubic hair and axillary hair, it is androgens. Staging for breast and pubic hair was given by Tanner, and that is called as Tanner staging, right? Then, abnormal puberty. For this, I want you to draw a table where you will have abnormal puberty on the left hand side. Then in the middle, you will have the definition, then the most common cause and the treatment of choice. So the first abnormal thing in puberty can be precocious puberty. Precocious puberty means that the puberty is happening early. And how much early? If breast development or thelarchy happens at the age of 8 years or menarche happens by the age of 10 years, that is called as precocious puberty. The most common cause of precocious puberty is idiopathic, and the treatment of choice for precocious puberty is GnRH. What you have to remember is that when you give GnRH continuously, then it decreases the estrogen. And when you give GnRH in a pulsatile manner, it increases LH, FSH and estrogen. So in case of precocious puberty, if puberty is happening at an early age, that means estrogen secretion is happening at an early age. That means we have to decrease the levels of estrogen in this female, and so we are going to give GnRH continuously, right? So the management is continuous GnRH. Let's talk about delayed puberty. Delayed puberty means absence of breast and absence of menstruation by 13 years of age, right? Or if there is no menstruation by 15 years of age, irrespective of whether the breast is present or not. So by 13 years of age, if there is no breast development and no periods. By 15 years of age, if there are no periods, irrespective of the fact whether the breast is developed or not, that is called as delayed puberty. And the most common cause of delayed puberty is constitutional delay. Now, if there is delayed puberty, that means we want to give the female estrogen, and then the treatment of choice becomes pulsatile GnRH, right? Now, one thing which you have to remember is that GnRH, it is released from the arcuate nucleus of the hypothalamus, right? The natural GnRH is released from the arcuate nucleus of the hypothalamus in a pulsatile manner. And this GnRH which we are giving over here, these are synthetic GnRH. And an example of synthetic GnRH is leuprolide, right? So if you are giving GnRH continuously, the synthetic GnRH continuously, it decreases the estrogen. And if you are giving the synthetic GnRH in a pulsatile manner, it increases LH, FSH and estrogen, right? So that is what you have to know about puberty in females. In males, you have to just remember one thing, that the earliest sign of puberty in males is testicular enlargement, and the most common time for puberty in males is 11.5 years, whereas the most common time for puberty in females is 10.5 years. At 10.5 years, breast development happens in female, breast budding happens, and menstruation, it happens normally after 2 years. So after 2 years of the appearance of breast budding, then the female is going to have menarche, or her first period, that is menstruation. Now, initially when a female starts menstruating, the initial few cycles, they are anovulatory. So initially when a female starts menstruating, the initial few cycles are anovulatory, and a characteristic of anovulatory cycles are that they are irregular, they are painless, and they may be associated with excessive bleeding. Excessive bleeding which is happening in a female of pubertal age group, that is called as puberty menorrhagia. So excessive bleeding which is happening in a female of pubertal age group, that is called as puberty menorrhagia. About puberty menorrhagia, you have to remember that in virgin females, per-vaginal examination is contraindicated. And obviously, if per-vaginal examination is contraindicated, so dilatation and curettage will also be contraindicated. So if they ask you management of puberty menorrhagia is all except, in that all except, always the answer will be dilatation and curettage, right? So this is what you have to remember about puberty in females as well as males. In males, there is just one thing, that is the first sign of puberty in males is testicular enlargement, right? Now, let's talk about a very, very important topic, and that is amenorrhea. Right? Now, the definition for amenorrhea, see, amenorrhea, first thing is it is absence of menstruation, and amenorrhea, it can either be primary or secondary. Primary amenorrhea means that a female has never experienced menarche. She has never had her periods. So if there is no menarche, then it is called as primary amenorrhea. There is no menarche, right? Secondary amenorrhea means that initially the female was menstruating normally, but from now for past 3 cycles or for past 6 months, she did not have any menstruation, right? Now we are going to talk about primary amenorrhea. Now the definition for primary amenorrhea and for delayed puberty is the same. So what was the definition for delayed puberty which I had told you? I had told you that if there is absence of breast or absence of menstruation by 13 years. Now, when you are defining primary amenorrhea, you are going to say that if menstruation is absent by 13 years of age, in absence of breast development, it is called as primary amenorrhea, or by 15 years of age, irrespective of breast development, that is called as primary amenorrhea. So you have to remember just 13 years and 15 years, both of them are fit into the definition of delayed puberty. In delayed puberty, by 13 years of age, if there is absence of breast and absence of menstruation, and by 15 years of age, if there is absence of menstruation, irrespective of breast. Same definition you apply to primary amenorrhea, that if by 13 years of age there is no menstruation in absence of breast, or by 15 years of age there is no menstruation irrespective of the presence of breast, that is called as primary amenorrhea, right? In primary amenorrhea, see, questions are asked very oftenly. 1 or 2 questions on primary amenorrhea you will definitely get in your paper. And for primary amenorrhea, I want you to make this chart, which is very, very important. Now, in this chart, you are going to make 1, 2, 3, 4, 5, 6, 7, 8 columns. First column will be your question or a case scenario. Second column will be of secondary sexual characteristics. Third column will be whether uterus is present or not. Fourth column will be the karyotype. Fifth column will be gonads. Sixth column will be other important point. Seventh column is diagnosis, and eighth column is treatment. Right? This is the most important table which you have to remember. Right? Now, your question can say that there is a young female with normal secondary sexual characteristics who's complaining of cyclical pain in abdomen every month but no menstruation. That is how the question is going to come to you. On local examination, there is a bluish hymen, and on ultrasound, uterus is present, and you will have to tell the diagnosis. Right? So I'm repeating the question. A female is coming to you with normal secondary sexual characteristics. She's having cyclical pain in abdomen every month, no menstruation. Local examination shows a bluish hymen, and on ultrasound, uterus is present. Now, so what they are telling about secondary sexual characteristics, the question is saying that the secondary sexual characteristics is present. In other words, breast is present, and just now I told you that the breast development depends on the estrogen. So that means in this female, the levels of estrogen is normal. Then the question will tell you that the uterus is present, and furthermore what you have to remember is that in these cases uterus is bulky, and I'll tell you why it is bulky. It is because of the collection of blood that is called as hematometra. Now, because secondary sexual characteristics are normal, that means estrogen is normal, and that means she's a normal female, and so her karyotype is 46XX. This is a normal female with karyotype 46XX. Now, since the question is telling you that the secondary sexual characteristics are normal and estrogen is normal, this female will be having gonads which are ovary, right? Her karyotype is 46XX. What you have to remember is that for the development of testes, you need Y chromosome. For the development of ovary, there has to be absence of Y chromosome. It's absence of Y chromosome which tells you that yes, the gonads will be ovary. Now, because the karyotype I'm telling you is 46XX, so the gonads have to be ovary. The other important point which they are telling you that on local examination, you are getting tensed bluish bulging hymen. Now, your diagnosis over here, the moment you see the catch point here is there you are getting normal secondary sexual characteristics, cyclical pain in abdomen, and bluish hymen. All these mean that this female is menstruating normally, but because of some obstruction in the passage, the menstrual blood is unable to come out, and that is what is called as cryptomenorrhea or concealed menses. And because the question itself is telling you that there is a bluish bulging hymen, that means her hymen is imperforate. So normally if you see a hymen is covered by a very thin membrane, and this membrane, it has a hole from which the menstrual blood keeps coming out. Now suppose there is a female in which the hymen is covered by a thin membrane, but there is no opening for menstrual blood to come out. This was normal. This is imperforate. There is no opening over here for menstrual blood to come out. So what will happen is this female will menstruate normally, but her menstrual blood will keep on collecting in the uterus, and that is why you are getting a bulky uterus which has collection of blood, and that is what is called as hematometra. Now the only treatment which you have to do is you have to give a cruciate incision on the hymen, and the female will start having her periods. The menstrual blood will come out, right? So the catch point here was patient is having cyclical pain in abdomen every month but no menstruation, and you get a bluish hymen, right? Okay, then coming to case 2. Now case 2, the question will say that there is a young female 46XX with primary amenorrhea, with normal secondary sexual characteristics, and with absent uterus, right? And you have to tell the diagnosis. Okay, so now what is the question giving you? Question is saying that the secondary sexual characteristic is normal. This is what the question is telling you. Question is telling you that the uterus is absent. Question is telling you that the karyotype is 46XX. Now, because the question is telling you that the karyotype is 46XX, and that means Y chromosome is absent. So in other words, the gonad have to be ovary, right? Now, in this case, what you have to remember is that when the question says that you are getting normal secondary sexual characteristics with absent uterus, it means that the uterus has not developed, and we know that the uterus develops from the Mullerian duct. So in this case, the problem is that there is Mullerian agenesis. In other words, both the Mullerian duct are absent. And because both the Mullerian duct are absent, that is why what structures will be absent? Uterus will be absent, right? The upper two-thirds of vagina will be absent. Then the fallopian tubes will be absent. Uterus will be absent. Upper two-thirds of vagina will be absent. Fallopian tube will be absent, right? Now tell me, ovaries. Ovaries, they develop from genital ridge. So that is why ovaries will be normal, because ovaries develop from genital ridge. Another structure which develops from Mullerian duct is the kidney system. So there can be renal anomalies or renal agenesis also. So you can get renal anomalies. Now, if you are getting renal anomalies also, then this is called as MRKH syndrome. What is MRKH syndrome? Mayer-Rokitansky-Kuster-Hauser syndrome. MRKH syndrome, right? So again, I'm telling you, this is a young female with primary amenorrhea, normal secondary sexual characteristics, uterus absent. Always and always your diagnosis will be Mullerian agenesis, right? In Mullerian agenesis, you get uterus is absent, upper two-thirds of vagina is absent, fallopian tube is absent. Uterus is normal and lower one-third of vagina is normal. Why lower one-third of vagina is normal? Because lower one-third of vagina develops from the urogenital sinus, right? If Mullerian agenesis, in patient of Mullerian agenesis, you also get renal anomalies, that is called as MRKH syndrome. Now, because uterus is absent, that is why I cannot do anything about her menstruation. She cannot menstruate, right? The other problem which this female is going to face is that her upper two-thirds of vagina is absent. So this female cannot have a proper intercourse, and that is why the treatment becomes that you have to do a vaginoplasty. The name of the vaginoplasty is McIndoe vaginoplasty, right? And the time for doing vaginoplasty is just before or just after marriage, right? So this is what very important thing. They ask you what is the most common method for doing vaginoplasty. The most common method for doing vaginoplasty is McIndoe vaginoplasty. And what is the time for doing vaginoplasty? Very, very important question, just before or just after marriage, right? So that's case 2. Another very important question which they ask you here is ovulation normal? Yes, because ovaries is normal. That is why ovulation is also normal in Mullerian agenesis. Right? So that was case 2. Now, the third question or the third case which they can give you is that there is a young female with primary amenorrhea with proper breast development corresponding to Tanner stage 4 or stage 5. So, Tanner staging has 5 stages. If they say Tanner stage 4 and 5, that means the breasts are properly developed, right? With pubic hair and axillary hair belonging to Tanner stage 1 and 2. So they will say that this patient has scanty pubic hair and axillary hair. The question will give you this, that pubic hair and axillary hair are scanty corresponding to Tanner stage 1 and 2. And the patient comes to you with complaint of inguinal hernia. Now remember, whenever a question says that there is a patient who has proper breast development but pubic hair and axillary hair are scanty, always and always first come to the diagnosis, and the diagnosis is testicular feminizing syndrome or androgen insensitivity syndrome. The chromosome number for this condition is 46XY. That means they are males who are resistant to testosterone, right? So always, the moment you get that the breast is properly developed, but pubic hair and axillary hair are scanty and uterus is absent, always and always it has to be just one diagnosis, that is testicular feminizing syndrome or androgen insensitivity syndrome, right? The chromosome number being 46XY, right? Now, in this case, what are they telling you about? What is the question telling you about secondary sexual characteristics? The question is telling that the breast is normal, but pubic hair is scanty, axillary hair is scanty. The question is telling you that the uterus is absent. We know that this is a case of androgen insensitivity syndrome and or testicular feminizing syndrome. So the karyotype is 46XY. Right? Now, because Y chromosome is present, that is why gonads will be testes. Just now I told you, if Y chromosome is present, gonads have to be testes. If Y chromosome is absent, then the gonads have to be ovaries. Now, these gonads or these testes, they are intra-abdominal, and that is why there are increased chances of malignancy. And because they are intra-abdominal, that is why patient presents to you with inguinal hernia. So actually it is not inguinal hernia, actually it is intra-abdominal testes. Now, because these males are androgen insensitive, that is why their external genitalia will resemble females. In other words, they will have ambiguous genitalia. So whenever a male's genitalia, external genitalia resembles female or vice versa, it is called as ambiguous genitalia, right? Now, in this case, what will be the treatment? The treatment will be that because they have intra-abdominal testes and intra-abdominal testes have increased chances of malignancy, so I will have to remove those testes. In other words, I will have to remove the gonads at 14 to 15 years of age. Number two, I will do a vaginoplasty in them also, right? So these are males who look like females and throughout their life they have been looking like females, so I will have to make them capable of getting married. So I'm going to do a vaginoplasty. The technique for vaginoplasty again will be McIndoe vaginoplasty, and the time will be just before or just after marriage, right? And because you are taking them as females, you are letting them be females, you are not taking them as males, so you will have to give them some or the other hormone, and the hormone which you are going to give them is estrogen. You have removed the gonads, so now they don't have any hormone, any sex hormone, so you will have to give them estrogen because you are letting them be females. And because these females, these persons, they do not have any uterus, their uterus is absent, so they don't have any risk of developing endometrial cancer. So I can give them only estrogen. I don't have to give them any progesterone because they don't have any uterus, so no risk of endometrial cancer. So the treatment for testicular feminizing syndrome is you have to remove the gonads. What is the age for removing the gonads? 14 to 15 years. Do a vaginoplasty. What is the age for doing vaginoplasty? Just before or just after marriage, and give them estrogen. Most of the time you are going to be asked a diagnosis, and the diagnosis is based on the fact that breast development is proper, corresponding to Tanner stage 4 or 5, pubic hair and axillary hair are scanty, and patient coming to you with inguinal hernia, it has to be androgen insensitivity syndrome or testicular feminizing syndrome. Clear to all of you? So this was case 3, right? Now, here I want you to note one more thing. What is the most common cause of ambiguous genitalia in males? I told you that ambiguous genitalia in males means that the genitalia of male is resembling female, and the most common cause of ambiguous genitalia in males is testicular feminizing syndrome. What is the most common cause of ambiguous genitalia in females? It is congenital adrenal hyperplasia. Very, very important questions, right? Now, till now, the 3 cases which I have discussed with you, in these 3 cases, The secondary sexual characteristic, that is the breast, was normal. In cryptomenorrhea also the breast was normal. In Mullerian agenesis also the breast was normal, and in testicular feminizing syndrome also the breast was normal. Now suppose you get a case or a question where they say that there is a female with primary amenorrhea with absent secondary sexual characteristics and with short stature. Now the moment they say that the secondary sexual characteristic is absent and patient has a short stature, she has a uterus present but the uterus is infantile, your diagnosis immediately has to go to Turner's syndrome. Immediately Turner's syndrome. So what I am saying is secondary sexual characteristic absent, short stature, uterus present but small. Diagnosis is Turner's syndrome. In Turner's syndrome, the karyotype is 45XO. That is the karyotype in Turner's syndrome. Now, in Turner's syndrome, because Y chromosome is absent, that is why we know that the gonads will be ovary. Now, another very important point you have to remember is that ovaries develop. See, ovaries are formed. Why? Because Y chromosome is absent. That is why ovaries are formed. But for proper development of ovaries, ovaries need both the X chromosomes. So ovary will be present or ovary will be absent. It totally depends on Y chromosome. Ovary will be present only if Y chromosome is absent. But ovaries will be properly developed or not. For that, it needs both the X chromosomes. In case of Turner syndrome, very, very important concept which you have to remember is that because Y chromosome is absent, so the gonad has to be ovary. But because only one X chromosome is present, only one X chromosome is present, that is why the ovary is not properly formed. And that is what is called as a streak gonad, right? So let's see all the important points here. Let's fill up the table. So in the table, we know that the question itself is saying that secondary sexual characteristics are absent. And we know the reason now. If ovaries are not properly developed, the levels of estrogen will be less. And because the level of estrogen will be less, so the secondary sexual characteristic will be absent. Now, the question itself is telling you that the uterus is present, but the uterus is small or it is infantile or hypoplastic, right? Karyotype, just now we came to a conclusion that the diagnosis is Turner syndrome. So, the karyotype has to be 45XO, right? Gonads, we did that, yes, the gonads are streak ovaries, and because it is streak ovaries, the levels of estrogen will be less, and so secondary sexual characteristics will be absent. Other important points which you will get here is that patient will have short stature. Her LH and FSH will be increased. Why? Because if there is less estrogen, so the negative feedback on FSH will be gone. So FSH levels will be increased. Right, and because she has streak ovaries, that is why she will not ovulate, and if she will not ovulate, so her progesterone will also be less, and because progesterone will be less, so the negative feedback on LH will be gone and her LH and FSH would be high. So in the table where we had written in those conditions where LH and FSH are high, I made you write just two conditions, number one menopause and number two Turner's syndrome. Apart from this, there is webbing of neck, there is shield-shaped chest. Then these patients, they are more prone to have heart disease, and the most common heart disease which you get in these patients is bicuspid aortic valve followed by the coarctation of aorta. Right? Now, Turner's syndrome is an example of hypergonadotropic. So here the levels of LH and FSH are raised, so it is hypergonadotropic, and because the levels of estrogen are decreased, hypogonadism, right? So Turner syndrome is an example of hypergonadotropic hypogonadism, right? The problem in these patients is that the ovary is not forming estrogen and progesterone, so you will have to give them estrogen and progesterone. Obviously, because they have a uterus, I cannot give them estrogen alone. I have to give them a progesterone also. Right, so treatment is that from 12 years of age, you start giving them estrogen and progesterone, and because they have short stature, you will have to give them growth hormones, and you will have to give them supplementations of calcium and vitamin D, because they have less estrogen, so they have more chances of osteoporosis, and that is why you will have to give them calcium and vitamin D also, right? So this is what you had to know about Turner's syndrome, and these are the details also about Turner's syndrome. Right? Now suppose you get a question which says that there is a female with primary amenorrhea with absent secondary sexual characteristics. Her height is normal and uterus is present. Right? Now, same thing in Turner's. The only difference is in Turner's, the question was saying that the stature is short. Now the question is saying that the height of the patient is normal. Her karyotype is 46XX. Now the moment they say that the secondary sexual characteristic is absent and height of the patient is normal, you have to think of only one diagnosis, and that is Kallmann syndrome. Right? Kallmann syndrome. So if the question is short height, absent secondary sexual characteristics, the answer was Turner's syndrome, right? If the question is normal height, absent secondary sexual characteristic, the answer is Kallmann syndrome. Now, what happens in Kallmann syndrome? In Kallmann syndrome, there is hypothalamic failure. In other words, the levels of GnRH are decreased. Right? Now, if the levels of GnRH will be decreased, obviously LH and FSH will also be decreased. So, in Kallmann syndrome, LH and FSH are low, whereas in Turner's syndrome, the levels of LH and FSH were high. And because LH and FSH are low, so obviously the levels of estrogen will also be low, because it is FSH which releases estrogen from the granulosa cells. And if estrogen is low, obviously there will be absent secondary sexual characteristic, right? So with this background, let's fill the table. So the question is telling you that the secondary sexual characteristics are absent, uterus will be present, karyotype is 46XX. Now, because karyotype is 46XX, gonads will be ovaries and gonads will be properly developed. The ovaries will be properly developed because both the X chromosomes are present. Important point is that the height of the patient is normal and levels of LH and FSH are low. Right? Now, because the levels of LH and FSH are low, that is why estrogen is also low. So, it is an example of hypogonadotropic hypogonadism. Because LH and FSH are low, it is hypogonadotropic. Because estrogen is low, hypogonadism. Right? Kallmann syndrome, you don't need to know the treatment. So have you understood? Height of the patient normal, absent secondary sexual characteristics, Kallmann syndrome. It is an example of hypogonadotropic hypogonadism. Absent secondary sexual characteristics, height of the patient is short, Turner's syndrome, which is an example of hypergonadotropic hypogonadism. So let's talk about the most common cause of primary amenorrhea. The most common cause of primary amenorrhea, please note that the best answer is gonadal dysgenesis. If gonadal dysgenesis is given in your options, you're going to mark that. If that is not given, then you are going to mark Turner's syndrome. And you know the karyotype of Turner's syndrome is 45XO. The second most common cause of primary amenorrhea is Mullerian agenesis, in which the karyotype is 46XX. And the third most common cause of primary amenorrhea is testicular feminizing syndrome, which is 46XY. So you can see that in the most common cause of primary amenorrhea, second most common cause of primary amenorrhea, and third most common cause of primary amenorrhea, all of them have different karyotypes. In other words, if I ask you what is the best investigation for primary amenorrhea, you are going to say karyotyping. Similarly, if you see here, In both Mullerian agenesis and in testicular feminizing syndrome, uterus will be absent. In Mullerian agenesis, uterus will be absent because Mullerian duct has not developed. In testicular feminizing syndrome, uterus will be absent because here the gonads are, because they are males. And in males, the Mullerian duct does not form. So obviously here also the uterus will be absent. In Mullerian agenesis, the breast will be properly developed. In testicular feminizing syndrome also breast will be properly developed. The only difference is that in Mullerian agenesis, pubic hair and axillary hair will be well developed, but in testicular feminizing syndrome, pubic hair and axillary hair will not be well developed. So if they ask you what is the best test to distinguish between Mullerian agenesis and testicular feminizing syndrome, again it is karyotyping, because in Mullerian agenesis the chromosome number is 46XX, in testicular feminizing syndrome the chromosome number is 46XY, right? Okay, apart from that, yes, in Mullerian agenesis, you can do an IVP, intravenous pylography also. If you do intravenous pylography in Mullerian agenesis, you will get renal anomalies. In testicular feminizing syndrome, you will not get renal anomalies, but then that's not the good test. The best test to distinguish between Mullerian agenesis and testicular feminizing syndrome is karyotyping. Clear? So this is what I wanted you to know about primary amenorrhea. Let's talk about secondary amenorrhea. Now, as I told you, secondary amenorrhea means that a female did not have any periods for 3 cycles or for 6 months, then that is called as secondary amenorrhea. The most common cause of secondary amenorrhea is pregnancy, and that's a physiological cause, right? The most common pathological cause for secondary amenorrhea is PCOS or polycystic ovarian syndrome, right? Now, we will be talking about polycystic ovarian syndrome. In polycystic ovarian syndrome, the problem is that the female does not ovulate. And because a female does not ovulate, that is why progesterone is less. And if the progesterone is less, a female will not menstruate. For menstruation to happen, initially the levels of progesterone should be very high and then they should suddenly decrease. Then only menstruation happens. And in a patient of PCOS, there is no progesterone. No progesterone means no menstruation, right? Now, how are you going to get questions on secondary amenorrhea? So if your question says that there is a female with secondary amenorrhea with bleeding present after giving progesterone, so that means that in that female the progesterone was not there. When you gave her progesterone, and this is called as progesterone challenge test. So after doing a progesterone challenge test, bleeding was present. In other words, you gave her progesterone and then stopped and the bleeding happened. So because in polycystic ovarian syndrome, the patient did not have progesterone, she did not bleed. The moment you gave her progesterone, the problem was over and she started bleeding. So read your question very carefully. If the question says that there is secondary amenorrhea with bleeding present after doing a progesterone challenge test or after giving progesterone, it has to be polycystic ovarian syndrome and nothing else, right? Now, if your question says that there is secondary amenorrhea and there was no bleeding even after giving estrogen and progesterone. So this patient was given estrogen and progesterone and then both estrogen and progesterone were stopped. She did not have any bleeding. Then the diagnosis is Asherman syndrome, right? Now, you are giving estrogen and progesterone from outside like a normal menstrual cycle and still the female is not bleeding. This means there is some problem in the uterus and that problem is Asherman syndrome. Now, these are straight questions which will be asked. Secondary amenorrhea, there is a female who comes to you with secondary amenorrhea and you gave her estrogen and progesterone challenge test, but there was no bleeding. What is the diagnosis? You will say the diagnosis is Asherman syndrome. At what level the problem is present? The level at which the problem is present is the uterus or the endometrium. So what happens in Asherman syndrome? The questions which they ask you is, in Asherman syndrome, the problem is that there are intrauterine adhesions. So that is why I said the problem is in the uterus. and the endometrium is thin. That is what the problem happens in Asherman syndrome. The most common cause of Asherman syndrome is if you do a dilatation and curettage in the postpartum period. Because here the endometrium is thin, this thin endometrium will be shed at the time of menstruation, and that is why patient complains of less bleeding, and the term which is used for less bleeding is hypomenorrhea, or later on patient can come to you with amenorrhea. Investigation of choice in Asherman syndrome is if you can see the adhesions inside the uterus, and whenever you want to see inside the uterus, you will have to go for hysteroscopy. Management is with hysteroscope, you can not only just diagnose these adhesions, you can cut the adhesions at the same time. In other words, you are going to go for hysteroscopic adhesiolysis. And so that the adhesions do not form again, you will insert an IUCD. Now, both these things have taken care of one problem, and that was intrauterine adhesions. But in Asherman syndrome, there is another problem, that the endometrium is thin. So I need to build the endometrium, and today only we were saying that the hormone which proliferates the endometrium is estrogen. In other words, if I want to make her endometrium proliferated, I have to give her estrogen. But if I give her estrogen alone, it will result in endometrial cancer. So I am going to give estrogen plus progesterone. So the complete management of Asherman syndrome is hysteroscopic adhesiolysis followed by IUCD insertion or a balloon catheter so that the adhesions do not form again, followed by estrogen and progesterone, right? Now, the third question can come as there is a patient of secondary amenorrhea and there is failure to lactate the baby. Now, whenever question comes like this, that there is failure to lactate the baby, it has to be a case of Sheehan syndrome, right? So remember these points. Question coming to you with failure of lactation, mark it as Sheehan syndrome. Now, what happens in Sheehan syndrome? In Sheehan syndrome, there is postpartum necrosis of the anterior pituitary gland due to PPH. Right, so after delivery, patient had excessive bleeding and that led to the necrosis of the anterior pituitary gland. So all the hormones which are formed by the anterior pituitary gland will decrease, and so LH and FSH will decrease. And if LH and FSH will decrease, obviously estrogen and progesterone will decrease and a female will not menstruate. So that table was very important where I was telling you what are the causes of decreased LH and FSH, which was PKOS. Remember the mnemonic, where S was for Sheehan syndrome, right? Now, the fourth scenario which they can give you is that there is a second patient with secondary amenorrhea with galactorrhea, right? Headache and visual disturbances. Now, the moment this term galactorrhea comes, we know that the problem has to be that there is increase in prolactin. So, the cause is prolactinoma. Prolactinoma means a prolactin secreting pituitary tumor. Now, whenever the levels of prolactin are high, if you remember that table of LH and FSH, I told you that whenever the levels of prolactin are high, prolactin decreases GnRH, and because prolactin decreases GnRH, it will decrease LH and FSH. And obviously, if LH and FSH are decreased, patient will come to you with amenorrhea. And because prolactin levels are high, that is why patient is coming to you with galactorrhea. And because it is a pituitary tumor, prolactinoma is a prolactin secreting pituitary tumor, and pituitary tumor will come, patient will have headache, and because it is near to optic chiasma, patient will have visual disturbances. So whenever question says that there is secondary amenorrhea with galactorrhea, with headache and visual disturbances, always and always it has to be a prolactinoma, right? The investigation of choice for prolactinoma is MRI. The drug of choice for increased prolactin, a prolactinoma most of the times is a microadenoma, and you will have to give drug treatment or medical management. So the drug which you are going to give for increased prolactin level is cabergoline. But For if the prolactinoma patient is coming to you not because to get treatment of prolactinoma, she is coming to you because she has infertility. Obviously, if she has decreased LH and decreased FSH, she is going to come to you with complaint of infertility. So if patient is coming to you because of infertility, then you are going to give bromocriptine, because bromocriptine not only decreases the prolactin levels, it also brings about ovulation. So normally the drug of choice for increased prolactin is cabergoline, but if they say that the patient is a prolactinoma patient is coming to you with complaint of infertility, then the drug of choice becomes bromocriptine. Now, one thing which I forgot to tell you, which is very, very important here, is about Kallmann syndrome. In Kallmann syndrome, one very important point which I missed was, in Kallmann syndrome, patient is going to come to you with anosmia. Always. In Kallmann syndrome, remember that there will be decreased GnRH secretion and there will be anosmia. So this is one thing which will tell you that it is a case of Kallmann syndrome, that the height of the patient is normal, there are absent secondary sexual characteristic, and patient has anosmia. Please include this in your points. Very, very important point. In Kallmann syndrome, anosmia, that is inability to smell, is also present, right? So this was about primary and secondary amenorrhea. Now the last condition could be that they give you a question where they say that there is secondary amenorrhea and patient has high LH and high FSH. Now again, I'm telling you, the table which I gave you there was very, very important, right? Where I told you the conditions in which LH and FSH are high and conditions in which LH and FSH are low. If you remember the conditions in which I told you LH and FSH are high, there was one condition was Turner's syndrome. In Turner's syndrome, patient will not come to you with secondary amenorrhea. She's going to come to you with primary amenorrhea, right? Second condition is menopause. So this means that this female is having premature menopause or premature ovarian failure. So whenever the levels of LH and FSH are high and patient is having secondary amenorrhea, it has to be premature menopause or premature ovarian failure, right? So this is how you are going to do questions on primary and secondary amenorrhea. Like in primary amenorrhea, the best investigation was karyotyping. In secondary amenorrhea, the best investigation is hormonal study, right? So this is all what you have to know about amenorrhea topic in general. Very, very important. Don't forget to revise these tables before you go for your exam. Now let's see some important points on hyperestrogenic conditions like PCOS, fibroid and endometriosis. So let's talk about PCOS first. In PCOS, that you know, it's called as the Steen-Leventhal syndrome, and that's the most common cause of hirsutism. Now for hirsutism, there is a score which is called as the Ferryman-Galway score. Very, very important. The pathology in PCOS is that the ovaries, the theca cells of the ovaries, they produce excessive androgen, and this excessive androgen in adipose tissue, with the help of enzyme aromatase, it gets converted into estrogen. And when androgen is converted into estrogen, then the most common estrogen which is formed is E1. That is why the ratio of E1 is to E2 in a PCOS patient is 2:1. Whereas normally if you see E1 is to E2 is 1:2. So that means normally E2 is more in a female, but in PCOS patient E1 is more, right? Similarly, if you talk about the LH is to FSH ratio, the LH is to FSH ratio in a PCOS patient is 2:1 or 3:1. In case of PCOS patients, there is no LH surge, and because there is no LH surge, there is an ovulation, and the reason for infertility is an ovulation. Very, very important question, that why infertility happens in PCOS patient? It is because of an ovulation. Now, an ovulation means that the follicle, the primary oocyte, is not getting converted into secondary oocyte. So what happens to the follicles? The follicles will not rupture, and these follicles, they are arranged around the periphery of the ovary in a necklace pattern, right? So on ultrasound, you get a necklace pattern in case of PCOS, right? Apart from all this, in PCOS patients, there is insulin resistance, and because of insulin resistance, there is acanthosis nigricans, which means that there is darkly pigmented patches in the nape of neck and in axilla, and in future these patients can have diabetes, and most of these patients of PCOS are obese, but that does not mean that obesity is a criteria to diagnose PCOS. The criteria to diagnose PCOS is called as Rotterdam criteria. In Rotterdam criteria, two of the following three should be present to say that the person has PCOS. And these three are: number one, increased androgen. This increased androgen can be in the form of hirsutism, or it can be in the form biochemically it can be in the form of excessive androgens. Number two, ovulatory dysfunction, which manifests in the form of menstrual irregularities. And number three is the ultrasound criteria. On ultrasound, you will see that there are more than equal to 12 follicles in the ovary. The size of the follicles will be 2 to 9 millimeters, that means less than 1 centimeter, and the volume of the ovary will be more than 10 cc. This ultrasound criteria, it should be present in one or both the ovaries, right? Now, out of these three criteria, any two criteria should be present to classify a patient as a patient of PCOS. Either patient should have increased androgen, or patient should have ovulatory dysfunction, or on ultrasound, follicles should be seen in the ovary, which should be more than equal to 12 follicles. The size should be less than 1 centimeter and volume should be more than equal to 10 cc. Right? Out of these three, any two should be present. Which means that once there was a question asked that there is a female who comes to you with hirsutism and her ovaries are normal. Now, so can ovaries be normal in a patient of PCOS? Yes, because if she is complaining of hirsutism and she is complaining of ovulatory dysfunction, then even if her ovaries are normal, still two criteria are fulfilled. Still patient can be a patient of PCOS. Right? So just because in your question it is written that ovaries are normal, please do not say that it cannot be PCOS. It can 100% be PCOS if patient has hirsutism and if patient has ovulatory dysfunction, right? Then let's talk about what hormones are increased in PCOS and what hormones are decreased. Androgens are increased in PCOS. These androgens in adipose tissue get converted into estrogen. So estrogen is also increased in PCOS. Estrogen has a positive feedback on LH. So the levels of LH are also increased in PCOS. There is insulin resistance in PCOS. So the levels of insulin are also raised in PCOS, and because androgens increase LDL, so the levels of LDL are also increased in PCOS. Now, because estrogen has a negative feedback on FSH, so the levels of FSH are decreased in PCOS. Because there is an ovulation, so the levels of progesterone are decreased. Because androgen increases HDL and androgen decreases HDL, so the levels of HDL are decreased, and sex hormone binding globulin is decreased in PCOS. Remember that, right? So these are the list of hormones which are increased and decreased in PCOS, a very, very important table for you to copy and to remember, right? Then, how do you manage PCOS? The management of PCOS, it depends on the problem with which the patient is coming to you. If patient is coming to you with a complaint of insulin resistance, the drug of choice becomes metformin. Now, if patient comes to you with irregular cycles, the drug of choice becomes OCPs. If patient comes to you with hirsutism, again the drug of choice is OCPs. Right? So remember this, the management depends on the problem with which the patient is coming to you. Now, if patient comes to you with infertility, then the first line treatment, the drug of choice is letrozole, which is an aromatase inhibitor. So it will prevent the conversion of androgens into estrogens. The second drug of choice is clomiphene citrate, which is a selective estrogen receptor modulator drug. Please remember here that the drug of choice is not clomiphene citrate. The drug of choice has changed and it has become letrozole. Only if letrozole is not given in the options, then you are going to mark it as clomiphene citrate. The second line treatment is HMG, and if you remember, I told you HMG is synthetic LH and FSH. And one of the second line treatment is a surgery which is laparoscopic ovarian drilling. The third line treatment is GnRH, and GnRH you are going to give in a pulsatile manner, right? Why? Because when you give GnRH in a pulsatile manner, it will increase LH and it will increase FSH. So if FSH will be increased, number of follicles will get mature, and because LH will increase, it will lead to ovulation, because LH surge is responsible for ovulation, right? Now, very important thing which you have to remember is what are the conditions in which you have to give GnRH in a pulsatile manner, and what are the conditions in which you have to give GnRH continuously. Now, you have to give GnRH in a pulsatile manner only in two conditions: in delayed puberty and for ovulation induction, like you are doing in PCOS. So all these are ovulation inducing drugs, because in PCOS infertility is due to anovulation. So I have to give drugs which bring about ovulation. So all these drugs which I am going to tell you here are ovulation inducing drugs, which I have already told, right? All these are ovulation inducing drugs. And continuous GnRH is given in all those conditions where the levels of estrogen are high. So in all hyperestrogenic conditions, you will give continuous GnRH. Now, these hyperestrogenic conditions are in case of precocious puberty, in case of endometriosis, in case of fibroid, right? So these are the conditions in which you give pulsatile GnRH and continuous GnRH, right? So this is how you treat infertility in a patient of PCOS patient. And now, as you can see, in PCOS, it is very easy to treat infertility. You just have to give letrozole or clomiphene and her infertility is treated. So if someone asks you what is the most common cause of reversible infertility, most common cause of reversible infertility is PCOS, right? Now, remember that osteoporosis is not a complication of PCOS. Why? Because in PCOS patients, levels of estrogen are high. Osteoporosis will occur in a female in whom the level of estrogen is low. But in PCOS, the levels of estrogen are high. That is why osteoporosis can never be a complication of PCOS. Ovarian cancer is plus minus. It may be seen or it may not be seen in patients of PCOS. Why I'm telling you this is because you get long-term complication of PCOS or long-term complication of anovulation are all except. In that all except, you have to look for osteoporosis first. If you get osteoporosis, mark osteoporosis. If you do not get osteoporosis, mark ovarian cancer, because ovarian cancer, some studies say that it is a complication, some studies say that it is not a complication. The confirmed complications of PCOS, what are they? The confirmed complications of PCOS are diabetes. Confirmed complication of PCOS is that because there is excessive androgen, it can lead to heart disease. Confirmed complication of PCOS is because there is excessive estrogen, it can lead to endometrial cancer. It can lead to breast cancer. Then confirmed complication is because patient is obese. So they can be metabolic X syndrome. Right? They can be sleep apnea syndrome. Right? So these are confirmed complications. The complication which is not confirmed is ovarian cancer, and the complication which never happens is osteoporosis. So that's all what you need to know on PCOS. Right? Now let's check out what you need to know on endometriosis. Now, endometriosis, what is endometriosis? All of you know that it is occurrence of endometrial outside the uterus. So, if endometrial tissue is present outside the uterus, that is what is called as endometriosis. The most common site for endometriosis is the ovary, and that in the ovary, the endometriosis occurs in the form of chocolate cyst, or it is called as endometrioma. The second most common site is the pouch of Douglas. Right? Now, the most common symptom of endometriosis is secondary dysmenorrhea, and the most common cause of secondary dysmenorrhea is endometriosis. In endometriosis, you can get a triad of dysmenorrhea, infertility, and dyspareunia. What is dyspareunia? Pain at the time of intercourse. The investigation of choice for endometriosis is laparoscopy. Very, very often asked question. So if one question has to be asked on endometriosis, it has to be the investigation of choice. You cannot afford to forget this statement, right? Now, on laparoscopy, you get a gunshot appearance or a powder burn appearance in endometriosis. The theory which explains that why endometriosis occurs is Sampson's theory of implantation or Sampson's theory of retrograde menstruation. Right? That's the most common theory which explains why endometriosis occurs. Now, management of endometriosis is always, it is going to be medical management. Endometriosis is hyperestrogenic condition. It is an hyperestrogenic condition. So my aim is to bring the levels of estrogen down. Now remember, there are 5 drugs always which can be used whenever the levels of estrogen are high. So these 5 drugs are, guys, please let depression go. These are the 5 drugs which can be used in any hyperestrogenic condition. So when I told you that hyperestrogenic condition is fibroid also, right? So in fibroid also you can use these 5 drugs. Guys, where G stands for GnRH, and today only I told you that you have to give continuous GnRH, and example of synthetic GnRH is leuprolide. P stands for progesterone. Right? Whatever are the actions of estrogen, opposite are the actions of progesterone. L stands for letrozole. Letrozole, just now we did, is an aromatase inhibitors. D stands for danazole and G stands for gestrinone. These 5 drugs, they have to be on your tips. Right? Guys, please let depression go. These are 5 drugs which bring down the level of estrogen and are used in all hyperestrogenic conditions, right? Hyperestrogenic conditions are fibroid and endometriosis, right? So these 5 drugs you can use in endometriosis, and the management of choice of endometriosis is medical management, always. And these are the 5 drugs which you will use. Apart from these 5 drugs, you can also use mifepristone. Mifepristone is a progesterone antagonist. Now you will say that, ma'am, we are using progesterone also and progesterone antagonist also. Yes, we are using progesterone antagonist. Why? Because mifepristone brings about endometrial atrophy. And when it will bring about endometrial atrophy, even the endometrium which is not present in the uterus but outside the uterus will also get atrophied, and so endometriosis will be cured, right? So this was what you had to know about endometriosis. Then a similar condition is adenomyosis. In adenomyosis, the endometrium is present inside the myometrium, and that is why patient will come to you with a bulky uterus, but the size of the uterus will never be more than 12 to 14 weeks pregnant uterus size. It will never be more than that, right? The most common symptom in adenomyosis is menorrhagia. Why? Because the uterus is bulky. Right? So the surface area of the bleeding increases. So there is a lot of bleeding, and lot of bleeding is called as menorrhagia. Apart from that, patient will also have dysmenorrhea, right? Now in adenomyosis, you get a multiparous female more than 40 years who will come to you. Whereas in endometriosis, the female is nulliparous, right? So endometriosis is more common in nulliparous female, adenomyosis is more common in multiparous female. The investigation of choice in endometriosis was laparoscopy. The investigation of choice in adenomyosis is MRI. Management of endometriosis was medical management, management of adenomyosis. You are getting a female more than 40 years who is coming to you with excessive bleeding. My first thing is that maybe she has cancer, and every time I just cannot be confused whether it is cancer or whether it is adenomyosis. So it's better that I remove her uterus. So management of adenomyosis is hysterectomy. That's the best management. If the female refuses hysterectomy, then I'm going to insert Mirena. Mirena is a progesterone containing IUCD, and the progesterone in Mirena is levonorgestrel. So it's a levonorgestrel containing IUCD, right? So this is what you have to remember about endometriosis and about adenomyosis. So now the important points which you have to know about fibroid. Fibroid is again one of the hyperestrogenic conditions, and fibroid is the most common pelvic tumor in females. It's the most common benign tumor of the females also, and it is not only dependent on estrogen, it is also dependent on progesterone. So it's an estrogen and progesterone dependent tumor. So it's the most common pelvic tumor. It's the most common benign tumor in females. Most common variety of fibroid is a uterine fibroid, and in uterine fibroid, the most common is intramural fibroid, followed by the submucous variety and then the subserous variety. To begin with, all fibroids are intramural, and then if they grow towards the uterine cavity, then they are called as submucous, and if they grow towards the peritoneal cavity, they are called as the subserous. Maximum symptoms are seen with submucous fibroid. Maximum chances of abortion are with, so this over here is a submucous fibroid. So you can see maximum symptoms will be seen with submucous, maximum chances of abortion will be seen with submucous, and maximum chances of infertility will also be with a submucous fibroid. The most common presentation in a fibroid, mostly patients are asymptomatic, but if they ask you the most common symptom of fibroid, then it's menorrhagia. That means excessive blood loss. Remember, amenorrhea is never seen in fibroids. Amenorrhea is never seen in fibroids, right? Then the fibroid in which you get urinary symptoms, they are cervical fibroid. In cervical fibroid, you are going to get urinary symptoms. Anterior cervical fibroid presents with increased urinary frequency, and posterior cervical fibroid presents with urinary retention, right? Then degenerations. The most common degeneration in a fibroid is a hyaline degeneration, very, very important. Rarest degeneration or rarest change to occur in a fibroid is malignancy or sarcomatous degeneration. Either it is called as malignancy or sarcomatous degeneration. Now, the chances of malignancy in a fibroid, very important, it's less than 0.5%. And malignancy is most common in a submucous fibroid, right? Now, if they ask you which is the most common degeneration, you are going to say it's hyaline degeneration. But if they ask you most common degeneration in a postmenopausal female, now in postmenopausal female, all the organs, they undergo atrophy. I'm talking about the reproductive organs. So the uterus will also undergo atrophy, and the fibroid, which is an estrogen and progesterone dependent condition, the levels of estrogen and progesterone, they decrease in menopause. So the fibroid also undergoes atrophy. So the most common degeneration in a postmenopausal female is atrophy. Then the degeneration which occurs due to venous thrombosis, the degeneration which occurs due to venous thrombosis is red degeneration. Or if they ask you which is the most common degeneration in pregnancy or which degeneration is most specific for pregnancy, then it's red degeneration. Both the answers are red degeneration, right? Now, so just now we were talking that red degeneration is most specifically seen in pregnancy, and in pregnancy, red degeneration is seen in second trimester. Patient is going to come to you with abdominal pain, fever, and increased ESR, but there is no infection, right? The fever and ESR which is increased is because of the secondary changes. It is not because of the degeneration as such. Red degeneration occurs because of venous thrombosis, right? That is why it is red in color and patient presents to you with abdominal pain. Management of red degeneration is you never have to do surgery. Always and always you have to go for conservative management. That's a very, very important question which is asked. Red degeneration is most commonly seen in second trimester. That's also a very, very important question, right? So this is what you needed to know in general about fibroids. Management of fibroid is surgery. Now, surgery depends upon whether you want to remove the fibroid only or whether you want to remove the uterus also. If the female is young and you want to remove only the fibroid, the surgery is called as myomectomy. But if you are removing the uterus also, then the surgery is hysterectomy, right? So, always the best management for fibroid is surgical management, but this is the management of symptomatic fibroid. If your fibroid is asymptomatic, in asymptomatic fibroids, you don't have to do anything. You don't have to do anything. You do nothing. You just follow them up, right? Now, in asymptomatic fibroid, irrespective of the size of the fibroid, and this was AIIMS June 2020 question, they had said that a fibroid is corresponding to 12 weeks pregnant uterus size. What should be done? Nothing. If the fibroid is asymptomatic, just because of the size of the fibroid, I am not going to operate, right? But there are certain conditions in which in asymptomatic fibroid also you have to do surgery. And what are those conditions? Number one, if you are not sure about the nature of the fibroid. So if you do not know whether the fibroid is benign or malignant. Number two, if there is a subserous fibroid and it is likely to undergo torsion. In that case, again, in case of asymptomatic fibroid, you are going to do surgery. Number three, suppose a female comes to you with infertility and you have done everything to treat infertility, but there was no problem. I mean, you have done all the investigations, there wasn't anything, there was just an asymptomatic fibroid. So thinking that this asymptomatic fibroid may be the cause of infertility, you can go for operating or removing the fibroid. Similarly, in case of recurrent abortion. Now, you have done all the investigations for recurrent abortion, you did not get anything, only you saw that there is a fibroid in the uterus. Even though that fibroid is asymptomatic, then in this case, you can go for surgery. So these are the indications for doing surgery on an asymptomatic fibroid. But other than that, you do not do any management for asymptomatic fibroid, irrespective of the size of the fibroid. For symptomatic fibroids, the best management is surgery. If you want to remove only the fibroid, then it is myomectomy. That is done in young females. And if older females, if you want to remove the uterus and the fibroid, then obviously the surgery is called as hysterectomy. Medical management in fibroids is rarely done, and it is done only if patient refuses surgery or if there is any contraindication to surgery, or if you want to reduce the size of the fibroid before surgery, right? Otherwise, we don't go for medical management in a fibroid. Now, when you are doing medical management of a fibroid, there are two types of drugs which are available. Number one, drugs are those drugs which will decrease blood loss, but they will not have any effect on the size of the fibroid. Drugs which decrease blood loss are, number one, progesterone. As I told you, that fibroid is an estrogen and progesterone dependent tumor. So if you are giving progesterone, then the bleeding will decrease, but the size of the fibroid will not decrease. At least it is not increasing also, but at least it will not decrease, right? So the drug which decreases blood loss but does not decrease the size of the fibroid is progesterone. Now you will say, ma'am, how progesterone will stop the bleeding? See, progesterone is a drug which supports the endometrium. Why bleeding happens is because in menstrual cycle, the levels of progesterone suddenly fall, and when the levels of progesterone suddenly fall, the support to the endometrium is lost, and that is what is menstruation. Now, if suppose progesterone levels are maintained, if the progesterone levels remain high, progesterone will continue to support the endometrium and patient will never bleed. Same thing is happening in this fibroid patient. We are saying that the patient is having excessive bleeding. Now, when we say patient is having excessive bleeding, what does that mean? That means her endometrium is shedding excessively. So if I give her progesterone, the moment I give her progesterone, this progesterone will support the endometrium and the shedding will stop, so the bleeding will stop. So number one drug which you can give to decrease blood loss is progesterone. Number two, you can give a combination of estrogen and progesterone, that is, you can give oral contraceptive pill. And number three, you can give tranexamic acid, which is a non-hormonal drug. So these are the three drugs which decrease the blood loss, but they do not have any effect on the size of the fibroid. In other words, they will not decrease the size of the fibroid. So the next category of drugs is which decrease the size of the fibroid, and because they decrease the size of the fibroid, they also decrease the bleeding, right? They decrease the bleeding in turn, right? Now, today only I was telling you that fibroid is an estrogen and progesterone dependent tumor. So if fibroid is estrogen and progesterone dependent tumor, either you decrease the size, decrease estrogen, or you decrease progesterone, the size of the fibroid will automatically decrease. And when I was talking in endometriosis, I was telling you in endometriosis that the drugs which decrease estrogen, you can remember them by a mnemonic. Guys, please let depression go, or let go depression, however you want to learn it, where G stands for continuous GnRH, P stands for progesterone, L for letrozole, G for gestrinone, and D for danazol. Right? So these are the drugs which decrease estrogen. So in all hyperestrogenic conditions like endometriosis and fibroid, you can use these drugs. Now, because fibroid is also a progesterone dependent tumor, so if you decrease progesterone also, then also the size of the fibroid will decrease. And the drugs which can decrease progesterone are number one, ulipristal. Ulipristal is a selective progesterone receptor modulator drug. Right, there are only two uses of ulipristal. Number one, it is used in management of fibroid, and number two, it is used in emergency contraception. And number two, you can use mifepristone, which is an antagonist of progesterone, and the other name for mifepristone is RU486. Right, so these are all the drugs which you can use to decrease the size of the fibroid. To decrease blood loss, there were only three drugs: progesterone, OCPs, and tranexamic acid. Right? So this is all what you need to know about fibroid. Now, the next topic which I'm going to cover with you is menopause. Now, menopause means that now there are no more follicles in the ovary, right? Or it can also be called as the ovarian failure. The mean age for menopause is 51 years. In India, the age is 47 years. Premature menopause or premature ovarian failure means if menopause is occurring in a female less than 40 years. Delayed menopause means that menopause has not happened in a female more than equal to 55 years. Right? Delayed menopause also means that the female will be exposed to estrogen for a very long time, and whenever a female is exposed to estrogen for a very long time, it is a risk factor for endometrial cancer and ovarian cancer. So delayed menopause is a risk factor for endometrial cancer and ovarian cancer. Now, in menopause, the most common symptom is hot flushes, in which patient will have sweating, tachycardia, anxiety. This hot flushes is a vasomotor symptom, right? And this hot flush is because of estrogen withdrawal, right? Then in menopause, the levels of LH and FSH are high. And again, that table comes where I told you that increased LH and FSH are seen in menopause. Why? Because in menopause, there is ovarian failure. So if the ovaries are not functioning, there is less estrogen and there is less progesterone. So obviously the negative feedback on LH and FSH is gone. So the levels of LH and FSH are high in menopause, and this LH and FSH is excreted in urine of a menopausal female, and that is how HMG is prepared. What is HMG? HMG is human menopausal gonadotropin, which has synthetic LH and FSH, and this HMG is prepared from urine of a postmenopausal female, right? Now, The first line treatment of hot flushes in a menopausal female is HRT, and if the uterus of the female is intact, then I am going to give estrogen and progesterone. Although the symptoms in menopause are happening because of decreased estrogen, whatever symptoms you get in a menopausal female are because of decreased estrogen, but because the uterus of the female is intact, I just cannot give her only estrogen. I will have to give her estrogen and progesterone. If I give her only estrogen, it will result in endometrial cancer. On the other hand, suppose the female has got hysterectomy done. Now, in that case, if uterus is absent, then the HRT which I have to give is only estrogen. The other treatment which you can use for hot flushes is selective serotonin reuptake inhibitor, that is fluoxetine, right? Now, the second symptom which you get in menopause is osteoporosis. Why you get osteoporosis is because in menopause, the levels of estrogen are less, and estrogen is the one which is responsible for bone formation, right? So, when estrogen levels are less, patient will come to you with osteoporosis. The first line treatment of osteoporosis is bisphosphonates, right? Example, alendronate, palmidronate. First line treatment of hot flushes was HRT. First line treatment of osteoporosis is bisphosphonate. The other treatment which you can use for osteoporosis is HRT. The way in which HRT has to be given is same like hot flushes. If uterus is present, you have to give estrogen plus progesterone. If uterus is absent, you have to give only estrogen. Then you can give tibolone. Tibolone has estrogen and progesterone like action. And you can give raloxifene, which is a selective estrogen receptor modulator drug. One very important point to note over here is that in the management of hot flushes, we are not using raloxifene. But in the management of osteoporosis, we are using raloxifene, right? I'll come to raloxifene a little later. Now, HRT is used in menopausal females for treating hot flushes, where it is the first line drug. It is used in osteoporosis, where it is the second line drug, and it is also used for managing senile vaginitis. What is senile vaginitis? Senile vaginitis is the dryness of vagina which is seen in a postmenopausal female. So the management of senile vaginitis is you have to give topical estrogen cream. HRT is not used to protect coronary artery disease, right? So just because you want to prevent a menopausal female from having coronary artery disease, you are not going to give HRT. Rather than decreasing the chances of coronary artery disease, studies have shown if HRT is given in females to prevent, without any reason, you are just giving to protect the female from coronary artery disease, it has adverse effects. Instead of decreasing the chances of coronary artery disease, it increases the chances of coronary artery disease. So this is a very oftenly asked question. HRT is useful in all except, and in that except you will get coronary artery disease. Right now, this is what I wanted you to know about menopause. Now, in the entire gynae, there are certain drugs whose side effects are very, very important. And those drugs I have written here. So this is a very important table which you have to remember. So important drugs and their side effects. Number one drug is raloxifene, which is selective estrogen receptor modulator drug. Its side effect is hot flushes. That is why raloxifene is not used in treating hot flushes, because its side effect is hot flushes. So whenever they give you a question saying all of the following drugs are used in managing hot flushes except, in that except you will always get raloxifene, because raloxifene can never be used to manage hot flushes. Number two drug whose side effect is very important is danazol. The side effect of danazol is hirsutism. That is why danazol is not preferred in young females. And whenever you will get a question which will say all of the following drugs are used in managing hirsutism except, in that except you will always get danazol, because the side effect of danazol is hirsutism. If you remember, the drug of choice for hirsutism was OCPs, right? Number 3 drug whose side effect you have to remember is clomiphene citrate. The clomiphene citrate, its side effect is multiple pregnancy, and this percentage is very important. The chances of twin pregnancy or multifetal pregnancy with clomiphene citrate are 5 to 8%, and it can also lead to OHSS. What is OHSS? OHSS is ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. The chances of OHSS with clomiphene are less, and they are 1%. Then you have to remember HMG. As I told you, HMG is synthetic LH and FSH, which is prepared from urine of postmenopausal female. It is human menopausal gonadotropin. Now, the chances of multiple pregnancy with HMG are 30%. With clomiphene, it was 5 to 8%. And the chances of ovarian hyperstimulation syndrome with HMG are 5%. With clomiphene citrate, it was 1%. A very, very important table which you have to remember.